Hemochromatosis. This comprises disorders of iron hemostasis which cause an increase in iron absorption. What we ingest is either heme iron or non-heme iron. The heme iron is from meat. It's broken down to amino acids and heme. The heme is oxidized to hemin, and that hemin gets transported into the intestinal epithelial cell, where the heme oxygenase acts and converts the ferric form into the ferrous form. Then we have the non-heme iron. This has the ferric form, and that is reduced to the ferrous form in the presence of ascorbic acid. That ferrous form is absorbed into the intestinal epithelial cell through the DMT1 transporter. Now, the ferrous form inside has to be again converted into ferric form, which it does by the hephaestin molecule, and that ferric form gets exported out of the intestinal epithelial cell through ferroportin, which is the only transporter of iron outside, exporter of iron outside the intestinal epithelial cell. That then gets bound to transferrin, which is transferred to the various tissues of the body. So what is the function of hepcidin? This is the master iron regulator. It binds ferroportin and it causes it to get internalized and degraded. It decreases the iron absorption from the gut, and it decreases the iron release from the macrophages and the iron stores. So what is the regulator of iron in the body? It's hepcidin. Low hepcidin levels are seen in anemia and hypoxia, and this causes an increase in iron absorption because there's more amount of ferroportin. High amount of hepcidin is found in inflammation, and the iron gets trapped inside the cells. There is low serum iron. What does hephaestin do? It converts ferrous to ferric form in the intestinal epithelial cell, so it's an oxidizer of iron, and only the ferric form can be bound to transferrin. Hemochromatosis, which is hereditary, is of two types: HFE related and the non-HFE related. HFE related, 83% of cases are due to C282Y gene mutation, which is on the short arm of chromosome 6. It is autosomal recessive in inheritance. The non-HFE related hemochromatosis is essentially of four different types. One is juvenile hemochromatosis, which is type 2A and 2B. 2A is hemojuvelin mutation. Type 2B is hepcidin or the HAMP mutation. Then there is the transferrin receptor 2 mutation or TFR2 mutation, which is type 3. Type 4 is ferroportin mutation, which is either a loss of function mutation or a gain of function mutation. Then we have the African iron overload. Causes of secondary iron overload are ineffective erythropoiesis, as in thalassemia major, sideroblastic anemias. Then we have congenital dyserythropoietic anemias, congenital atransferrinemia, liver disease, as in alcoholic liver disease, chronic hepatitis B and C, porphyria cutaneosa, NASH. Then there is iatrogenic causes like blood transfusions and IV iron overload. Clinical features. Many of them would be asymptomatic and detected just as an abnormal LFT on a routine examination. Family screens also detect patients. Some of them present with lethargy, apathy, and weight loss. Endocrine dysfunction would include 50% would have bronze diabetes because of iron deposits in the pancreas, hypopituitarism, hypothyroidism, hypogonadism presenting as impotence in 45% males, amenorrhea, decreased libido, Cardiac abnormalities, which include rhythm abnormalities and DCM. Joints, 40% have arthralgias, and the characteristic feature is the second and third metacarpal joint getting affected. Osteoporosis would be there. Skin abnormalities include hyperpigmentation in 70%, that's why it's called bronze diabetes. White nails. Then we have liver abnormalities. There could be just a hepatomegaly, there could be cirrhosis and hepatocellular carcinoma. Lab tests show transferrin saturation of more than 45%, can go up to even 100%. Ferritin more than 300 micrograms per liter. Hepatic iron index of more than 1.9. The normal is less than 1.1. Hepatic iron of more than 3,000 micrograms per gram dry weight. MRI in hereditary hemochromatosis, T2 weighted images show low signal intensity in the liver but normal in the spleen. But in secondary iron overload states, both the liver and the spleen have low signal intensity due to increased iron deposition in reticuloendothelial cells. The treatment is weekly phlebotomies until the hematocrit is less than 37%. Then we check the TSAT and the ferritin every 2 months. When the ferritin is 50 to 100 and the TSAT less than 50%, we do maintenance phlebotomies once every 2 months. If the patient cannot tolerate a phlebotomy, we can give them IV deferrioxamine, which is 20 to 50 milligrams per kg per day for 5 days a week as an infusion. There is also an oral option available which isn't so effective, that's oral deferrasirox. Post-liver transplant survival in 5 years is 35 to 55%.